Good afternoon. I'm going to talk about a project I did for NHS England. Oh, unmute. Can you hear me now? Yeah. So I'm going to talk about a project I completed for NHS England about 6 months ago, which focused on equity of access to community services after hospital discharge. So I'll look at a context about community services first of all. So it's a substantial service area. The service supports about 2.4 million people nationally. They deliver about 8 million contacts each month to those people, a mix of face-to-face and telephone contacts. They employ about a fifth of the entire NHS workforce and consume about an eighth of its budget. But it receives remarkably little attention from data scientists and analysts because the data until fairly recently has been so poor. But about 5 years ago or so, a new data collection system was put in place, the community services data set, and that data has been flowing ever since, improving very, very slowly in terms of quality. And I think it's reached a stage now where it is legitimate to start using this for real analytical projects. In fact, I think we need to start using it, because unless we start using it, it's never going to take the step changes in data quality that we really need in the future. It's a long way from being perfect, having looked at it in detail, but it is just about usable for some certain circumstances now, I think. I suspect actually local areas probably have better data on community service provision than through the national flows at the moment. But if you're interested in doing national data analysis, this is your primary source. The question that I've been asked to look at was about focusing on those patients who are discharged from hospital, older people who are discharged from hospital, back to their usual place of residence. And some of those will go on to receive some sort of contact from community services in the 30 days after discharge, some sort of supported community service contact. Now, we'd hope that the people who go on to receive these community services are the ones that need it clinically, rather than because of some other characteristic they have. And the question that I was asked to look at was whether those people that go on to receive community services after a hospital discharge, were those services equitably distributed across sexes, deprivation quintiles, and ethnicity? So the question was, if community services are distributed relative to need, we shouldn't see any differences in levels of access by sex, deprivation, and ethnicity. The question is, do we, having adjusted for need? So I had two data sets I was using. I was relying heavily on the admitted palliative care data set, which is a well-established data set with lots of good, useful variables in, data quality relatively high. And I was also using the community services contacts data set. I was looking at discharges that took place between June and July 2022, limiting those to just big blue discharge aged over 65, excluding things like day and night attenders. I had to exclude Dorset ICB, sorry to anyone from Dorset ICB, you might be here. Their community services data just didn't look usable at that point in time. I also made a few other exclusions, very long stay patients, for example. And I was interested in whether a patient received at least one face-to-face contact in the 30 days after discharge, so I was excluding attendances that were DNA'd or cancelled, for example. And the methods I used were general analytic logistic regression. I had about just short of 1 million observations to play with. The outcome variable was whether or not the patient had one or more face-to-face community service contacts in the 30 days after discharge. My variables of interest were sex, deprivation quintile, and ethnicity, and these were the other covariates that I controlled for in the model. So these are the variables that are attempting to adjust for need: age, ICB, treatment specialty, admission method, length of stay, Charlson comorbidity index, which is a measure of the sickness of the patient, level of acuity. And face-to-face contacts prior to being admitted into hospital. You'd expect people who are having a community service contact package prior to admission would be more likely to receive one after discharge. So I was trying to control for that as well. All of the analysis is undertaken in R, and there's a GitHub repo there if you're interested in the methods. So I'll just show you some of the descriptive statistics, first of all, about the million patients that I was investigating. I won't talk to these. These are just some illustration of the sort of characteristics of the study population. And these are some of the results. So of the 1 million people that I was looking at, having linked their hospital spell with their community service data set, we found that 21% of people went on to receive a community service contact after discharge, and 79.2% of people didn't. So what about the equity results? So the results of the model are very similar to the ones that Kate talked about. They're odds ratios, they take the same form. So I'll describe them first of all in text form, and then I'll show you a visual representation of the same result, so we can skip through the other results slightly more quickly. So the results by sex, first of all, take this form. So for female patients, the odds of receiving one or more community service contacts in the 30 days after discharge were 3% lower than for male patients being my reference category, having adjusted for age, deprivation, ethnicity, and all the other variables in the model. So this long line at the end is attempting to say, having adjusted for need, women were slightly less likely than men to receive a community service contact after discharge. This is an equivalent way of representing the same information in a visual form. So I have male, my reference category, with odds ratio of 1, and females, my category of interest, with an odds ratio of about 0.97, so 3% less likely to receive a community service contact. The whiskers around the dot here indicate the 95% confidence intervals around the odds ratio. So these are the results now by deprivation. So my reference category here was people living in the most deprived areas. And we actually found that people living in more affluent areas were less likely to receive community service contacts after discharge. Now, I've done lots of equity analyses, and generally speaking, when we're talking about a planned intervention, people living in deprived areas tend to have worse levels of access. So this was really quite a surprise for me. And it kind of does suggest that community services are actually playing an active role in trying to offset some of the inequities further up the pathway. Bear in mind, though, that I didn't incorporate any variables in our model about people's living conditions or circumstances. There's a question, if I had got data, for example, on whether people were living alone or had carers living with them or people who could look after them at home, would that have changed the results? I'd be quite interested in rerunning those results if I ever get that variable. But even so, these are health services. They're not care services. So, you know, is it legitimate for somebody at home to be providing health services to you as an alternative to an OT or a physio or a community nurse, for example? So I think these results are interesting and significant. These are the results by ethnicity. So my reference category here is white British. So we're saying relative to people from the white British category, were people from all the other ethnicities more or less likely to receive a community service contact? And there are some quite stark and worrying results here. So people from the Asian Bangladeshi community, more than 30% less likely to receive a community service contact, having control for all those need factors in the model than the white British population. We also see lower rates of access for the Asian Pakistani groups and the Chinese group. I have a not stated, not known group here, and that's quite large. There was quite a lot of patients, as you'll know, in the hospital data sets who don't have a stated ethnicity. But that group also had significantly less chance of receiving community service contact after discharge. No group with more chance than the white British, significantly more chance than the white British of receiving community service contact after discharge. So those are kind of my results. I just wanted to talk about the limitations now, first of all. So we didn't estimate need directly in this model. It would have been quite hard to do. I think trying to find a way of conclusively or comprehensively estimating need for community services would have been quite difficult. But instead, we've tried to control for it through a range of variables, which we think probably do vary alongside need. I think the variables that we've got in the model probably do a pretty good job of controlling for need. I mentioned we didn't have any variables in the model that captured patients' living conditions, whether they lived alone, whether they were living, the type of tenure they were in, the type of accommodation, whether they were living with family members, for example, whether there are people nearby who could come and help them. And I suspect that they would be interesting to incorporate those sorts of variables into the model. The data quality and completeness of the community service data set is a worry. But for the most part, I was relying on variables from the hospital data set, which I think we all use regularly, and we know that isn't perfect, but is usually good enough for most forms of data analysis. And just to sort of reiterate the conclusions, so we found that women were marginally less likely to receive a community service contact after discharge than men. We found that Bangladeshi, Pakistani, and Chinese people had a substantially lower rate of access to community services after hospital discharge. I think that requires a deep investigation. The figures here really were quite surprising. Not just the direction of the effect, but the scale of the effect really was quite remarkable. And then we found this unusual result where people living in more deprived areas had higher rates of access to community services after hospital discharge. I think further work to understand whether that's a function of people's living conditions will be worthwhile. That's everything from me.